Okay, let's unpack this. You know that feeling, right? When you're facing just a mountain of information, especially for something, well, complex, like a medical condition.
Oh, yeah.
It can feel like your brain's just, I don't know, swimming in treacle sometimes.
Definitely. Information overload is real.
So for this deep dive, we're tackling Juvenile Idiopathic Arthritis, JIA. We've got these revision notes, and we're going to boil them down to the absolute must-know stuff.
Yeah, make it manageable.
Exactly. This is super relevant, whether you're studying hard, seeing patients, or just wanting a really solid grasp of it.
Think of this as your high-yield briefing on JIA. We want to take all that crucial info and lay it out so it's easy to digest, and importantly, so it actually sticks.
Get you that aha moment, hopefully.
That's the plan, hitting all the key points efficiently.
Right. So consider this your focus guide. We're covering the definition, the potential causes, who might be more at risk.
What's happening biologically, the pathophysiology.
How to tell it apart from other conditions, which is, so key for exams.
Absolutely crucial, the differentials.
Then who it affects, what it actually looks like in a patient.
The investigations, how we manage it.
And, of course, the prognosis, what are the likely outcomes. And any complications to watch for. Ready to dive in.
Let's do it. So first things first, what exactly is juvenile idiopathic arthritis?
Okay, so simplest terms. JIA is a chronic condition, involves inflammation in the joints, and it affects children.
Right, and the key points for revision.
It has to start before age 16. That's the cutoff. And it needs to persist for at least 6 weeks.
Okay, and the main symptoms?
Classic inflammation signs. Joint pain, stiffness, often worse after rest swelling. And the big worry is potential long-term damage if it's not managed well.
And it's not just one single disease, is it?
No, absolutely not. That's a really critical point to get straight. JI is actually an umbrella term for several different subtypes.
Which are classified using the ILR criteria?
Exactly. The International League of Associations for Rheumatology criteria. It helps standardize things.
So what are the main subtypes we need to know?
Well, there's Oligoarticular JIA. That's the most common one, maybe around 50% of cases.
Oligo meaning few joints, right?
Yeah, typically 1 to 4 joints involved in the first 6 months. Then you've got Polyarticular JIA, poly meaning many.
5 or more joints in that first 6 months.
Right, and that one's split into RF negative, which is quite common, maybe 25%, and RF positive, less common, around 5%.
RF meaning rheumatoid factor.
Yes. Then there's systemic onset JIA, maybe 5–10%. That one has more body-wide symptoms.
Fevers, rashes, that kind of thing?
Exactly. We'll get into that.
Right.
Then a juvenile psoriatic arthritis, enthesitis-related arthritis. The percentages vary a bit for those, sort of 2 to 15%-ish.
Okay.
And finally, undifferentiated arthritis, basically, if it doesn't fit neatly into the other boxes.
Sort of variety. The key takeaway here is probably that the pattern of joints involved and whether there are those systemic features early on really helps differentiate them.
And guides treatment and prognosis down the line.
Precisely. Yeah.
Makes sense why the notes can feel a bit dense.
Yeah.
Okay, so what actually causes JIA? The etiology.
Well, this is where it gets a bit murky. As with many autoimmune conditions, unfortunately, the exact cause isn't known.
Right, the idiopathic part of the name.
Exactly. But the general thinking, the scientific understanding, is that it's a complex mix. It involves genetic factors, environmental factors, and immunological factors all interacting.
So not just one single trigger.
No. It seems there's likely a genetic predisposition that certain genes make the immune system, let's say, more susceptible to going off track.
Okay.
Then you might have environmental triggers, maybe things like infections that could set off an abnormal immune response in someone who's already genetically susceptible.
And then the immune system mistakenly attacks the joints.
That's the idea. It targets the body's own joint tissues, causing that inflammation we see.
It's like a puzzle, isn't it? We have some pieces, but not the full picture yet.
That's a great analogy. We know genetics, environment, immunity are involved, but exactly how they all fit together perfectly, we're still working on that. Understanding this interplay is key for developing better, more targeted treatments in the future, though.
Definitely. So, sticking with causes and contributing factors, who is more likely to develop JIA? What are the risk factors we should flag?
Well, a significant one is family history. Having close relatives with other autoimmune diseases like rheumatoid arthritis or lupus seems to slightly increase the risk.
Makes sense, the genetic link.
Yeah. And certain genetic markers are associated with JIA, though the notes don't specify which ones here. Interestingly, gender plays a role. Girls are generally more commonly affected overall.
Oh, okay. Any idea why?
The exact reasons aren't fully clear, but hormonal factors might play a part. It's a common pattern in many autoimmune diseases.
And environmental factors. You mentioned infections.
Yes, as we touched on, prior infections or other environmental exposures are thought to potentially trigger JIA in some individuals, but it's really important to stress these are associations, not definite causes.
Right. Having a risk factor doesn't mean you'll absolutely get JIA.
Exactly. It just increases the probability slightly.
Got it. Okay, let's zoom right into the joints now. What's actually happening at a biological level? The pathophysiology.
So the core process, fundamentally, is chronic inflammation of the synovium. That's the lining of the joint capsule.
Good.
And in JIA, this lining becomes persistently inflamed. It gets thickened. That's what we call synovial hypertrophy.
And what does this ongoing inflammation actually do? What are the consequences?
Well, that chronic inflammation is the engine driving the damage. Over time, it can erode and destroy the cartilage, which is the joint's cushion, and even damage the underlying bone. This leads to structural damage, pain, and ultimately functional impairment difficulty moving the joint properly.
And it's the immune system driving this.
Yes, it's immune dysregulation. The body's own immune cells and inflammatory chemicals are mistakenly attacking the joint tissues. The precise details of which cells and which pathways are most important are still being actively researched, but that's the basic idea.
Okay, so that explains the joint symptoms. Now, a child comes in with joint pain, swelling.
Yeah.
How do we make sure it is JIA and not something else? This feels like a really high-yield area for exams, the differential diagnosis.
Absolutely critical, both for exams and real-world practice. You have to have a broad differential when a child presents like this. We can sort of group them.
Okay, how?
Firstly, other autoimmune or inflammatory conditions, things like reactive arthritis or SLE systemic lupus erythematosus.
Right.
Then, a huge category is infection. You absolutely must rule out septic arthritis.
That's the bacterial infection in the joint.
Exactly. Typically affects just one joint, makes it hot, swollen, incredibly painful. Often there's a fever, and the child might refuse to bear weight on that limb at all. It's an emergency.
Okay, septic arthritis topped the list to exclude. What else infection-wise?
Osteomyelitis infection in the bone itself. That usually causes severe bony pain, maybe fever, and the child might stop using the limb.
Got it. Any other infection-related ones?
Yeah, you also need to think about reactive or post-infectious arthritis. This can happen after gut infections like salmonella or campylobacter, or after viral illnesses, rheumatic fever, Lyme disease. Those are also on the list depending on the context and geography.
Okay, so infections are a big group. What else?
Trauma is an obvious one. Always ask about recent injuries. Mechanical pain is another.
How does mechanical pain differ?
It's often related more to activity, might get worse through the day, and usually isn't associated with that prolonged morning stiffness you see in JIA.
Yeah.
Then there are things like pain syndromes, inflammatory bowel disease. Sometimes arthritis is the first sign of Crohn's or ulcerative colitis, especially if there's weight loss or a family history.
Right, the gut-joint connection.
Exactly. And then the really serious ones you have to consider are malignancies. Yes. Things like leukemia, lymphoma, or bone tumors like Ewing sarcoma can sometimes present with bone pain or joint swelling. Red flags here would be things like persistent night pain, unexplained weight loss, easy bruising, fevers.
Okay, malignancy, red flags, crucial. Anything else?
Finally, other connective tissue diseases, we mentioned SLE, but also things like juvenile dermatomyositis or sarcoidosis can have joint involvement.
Wow, that's quite a list to work through. Any tips for keeping them organized?
Well, thinking in categories helps. Infection, injury, trauma, other inflammation, autoimmune, post-infectious, mechanical, malignancy, other systemic, IBD, connective tissue.
Okay, like categories.
Yeah. And always, always pay attention to those red flags. Fever, night pain, weight loss, severe inability to bear weight. Those often point away from typical JIA towards infection or malignancy.
That's really helpful. So how common actually is JIA? What's the epidemiology look like?
In the UK, the prevalence is estimated at about 1 in every 1,000 children.
So not incredibly rare then.
No, definitely not. It's actually the most common chronic rheumatic disease of childhood. You will encounter it.
And does it affect certain groups more?
It affects children from all backgrounds. Globally, it's seen everywhere, though there might be some slight variations in which subtypes are more common in different regions. And as we mentioned with risk factors, overall, it is more common in females, but again, that can vary a bit depending on the specific subtype.
Okay, so let's get into the specifics of what it looks like, the clinical presentation. If a child comes in, what signs and symptoms make us think, could this be JIA?
Well, the general picture, as you'd expect, involves those joints, pain, swelling, stiffness. The stiffness is often characteristically worse in the morning or after a period of rest, like sitting still for a while.
Gelling, they sometimes call it.
Exactly, gelling. And they might have a limited range of motion in the affected joints, but it's not always just the joints.
Right, you remember in systemic symptoms earlier?
Yes, depending on the subtype, you can see things like fever, maybe a rash, fatigue, sometimes weight loss or poor growth.
Okay, let's break down those subtypes again, but focusing on their specific presentations. This seems vital for exams. Oligoarticular first.
Right, oligoarticular, few joints. So 1 to 4 joints involved in the first 6 months. It often starts before age 6 and typically hits the large joints, especially knees and ankles.
And the key association to remember.
ANA positivity. If the antinuclear antibody test is positive, there's a much higher risk of developing uveitis, that eye inflammation. So young child, few joints involved, especially knees, ankles, think oligoarticular, and definitely think about eye screening.
Got it. Polyarticular JIA next.
Polyarticular, many joints, 5 or more joints affected within the first 6 months. If it's RF negative, which is more common,
Right.
it often peaks in toddlers or preadolescents. It can affect both large and small joints.
And RF positive?
RF-positive polyarticular JIA tends to look more like adult rheumatoid arthritis. It often involves symmetrical inflammation in the small joints of the hands and feet. Systemic features might be a bit more prominent, and unfortunately, it often carries a higher risk of joint damage.
Okay, so RF status matters for pattern and prognosis. What about systemic JIA? That sounded quite different.
It really is. The hallmark here is systemic inflammation. You typically see a high spiking fever, often once a day, that has to last for at least 2 weeks.
Wow, 2 weeks of daily fevers.
Yeah, and often alongside that, there's a characteristic faint, pink, fleeting rash. It comes and goes, often with the fever. It's called an evanescent rash.
Okay.
Plus, you can get enlarged lymph nodes, enlarged liver and spleen hepatosplenomegaly, and inflammation of linings around organs like the heart or lungs called serositis. Arthritis might not even be the main feature at the very beginning.
So it can look like an infection initially.
Very much so. It's often a diagnosis of exclusion after ruling out infection and malignancy. Interestingly, it affects boys and girls fairly equally and often presents before age 5. Think fever, rash, systemic signs, plus arthritis.
Okay, and the other subtypes briefly. Juvenile psoriatic arthritis.
That's arthritis plus psoriasis, the skin condition. Or sometimes arthritis plus other features like nail pitting or dactylitis, those sausage digits, often with a family history of psoriasis.
And enthesitis-related JIA,
That involves either arthritis or enthesitis.
which is inflammation where tendons attach to bone.
Exactly. Common spots are the heel cord insertion or around the hips or knees. So you need arthritis or enthesitis plus some other specific criteria. It often affects the lower limbs and is more common in older boys, sometimes associated with HLA-B27.
And undifferentiated.
Still the catch-all. Doesn't meet criteria for the others or meets criteria for more than one.
Okay, that clarifies the different flavors of JIA. So we suspect it based on the clinical picture. What investigations do we actually order?
Right. Investigations help confirm inflammation, classify the subtype, and rule out other things. Blood tests are key.
What are we looking for in the bloods?
We look for markers of inflammation, C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR. They're often elevated when the disease is active.
Okay, CRP and ESR. What else?
A full blood count, or FBC. You might see a mild normocytic anemia that's anemia of chronic disease. The white blood cell count might be normal or slightly raised, but the differential count is usually normal. Platelets can be mildly raised too, as another sign of inflammation.
And the specific antibody tests, ANA and RF.
Yes. ANA antinuclear antibody, we test for that mainly because positivity, especially in oligoarticular JIA, flags that high risk for uveitis.
So it guides eye screening.
Exactly. Rheumatoid factor, RF, is tested primarily for classification distinguishing RF positive from RF negative polyarticular JIA, and sometimes HLA-B27 is tested, particularly if enthesitis-related JIA is suspected.
Okay, so bloods for inflammation, classification, and uveitis risk. What about imaging?
Imaging has its place. X-rays are often done, but they're usually normal in the early stages of JIA. They're more useful for ruling out other things, fractures, bone tumors, infections, or looking for later changes like joint space narrowing or erosions.
So not great for early diagnosis itself.
Not typically. Ultrasound can be much better early on. It's great for detecting joint fluid, seeing that thickened synovial hypertrophy, and it can even pick up early bony erosions sometimes.
Okay, ultrasound is useful. What about MRI?
MRI gives the most detailed picture. It can show bony changes, assess the extent of joint damage and synovitis really well. It's particularly helpful for joints that are hard to examine properly, like the hips or the sacroiliac joints.
And when would you stick a needle in the joint? Joint aspiration.
Primarily if you suspect septic arthritis. Remember that single, hot, swollen joint. You need to get fluid out to send for urgent microscopy and culture to rule out infection. That's crucial.
Right, absolutely. Okay, so we've done the history, exam, investigations. We've confirmed a diagnosis of JIA. What's the management plan look like?
Management is definitely a team effort. It needs a multidisciplinary approach. You've got the medical side, therapies, and really important psychosocial support for the child and the family.
Let's start with the medical side. Medications.
Medications are a cornerstone. Often the first step is nonsteroidal anti-inflammatory drugs, NSAIDs like ibuprofen or naproxen. They help with pain and inflammation, but don't change the underlying disease course.
So they're more for symptom control.
Largely, yes. To really tackle the disease and prevent long-term damage, you need disease-modifying anti-rheumatic drugs, or DMARDs.
Like methotrexate.
Methotrexate is a very common first-line conventional DMARD for many types of JIA. Others include sulfasalazine and leflunomide.
And then there are the newer biologic drugs.
Exactly. Biologic DMARDs target specific molecules involved in the inflammatory process. Things like TNF inhibitors, etanercept, adalimumab, infliximab, or drugs targeting other pathways like abatacept or tocilizumab. These have really revolutionized treatment for moderate to severe JIA.
What about steroids?
Steroids have a role, but we try to use them cautiously because of side effects, especially long-term in kids. Intra-articular steroid injections injecting directly into an inflamed joint can be very effective for oligoarticular JIA or for targeting one or two but particularly troublesome joints.
So localized treatment.
Yeah, minimizes systemic side effects. Systemic steroids, like oral prednisolone, are sometimes needed for severe polyarticular disease, systemic JIA, or serious complications, but usually for the shortest time possible. Topical steroids might be used for skin psoriasis in Juvenile Psoriatic Arthritis.
Okay. And you mentioned it's not just about meds.
Absolutely not. Non-drug management is vital. Physiotherapy is crucial to maintain joint range of motion, muscle strength, and overall function.
Keep them moving.
Yes. Occupational therapy helps children adapt daily tasks, things like dressing, writing, playing to manage their arthritis and stay independent.
Practical help.
Very practical. Hydrotherapy, exercising in a warm water pool, can be fantastic for reducing pain and stiffness while moving joints.
Sounds good.
And the team also needs to monitor for and manage potential risks from the JIA itself, like effects on growth, the risk of osteoporosis, and joint deformities.
Is surgery ever needed?
Sometimes, yes, but usually much later down the line if there's severe joint damage despite medical treatment. Options might include synovectomy, removing the inflamed joint lining, or eventually joint replacement, though that's less common in childhood.
Okay. And NICE guidelines provide specific pathways.
Yes. The NICE guidelines in the UK offer detailed recommendations on when to start and switch different DMARDs and biologics for specific JIA subtypes, ensuring treatment is tailored and evidence-based.
Right. A very comprehensive approach needed. So what's the long-term picture? What can we tell families about the prognosis?
It's really variable. That's the honest answer. It depends heavily on the subtype, how severe it is at the start, how quickly it's diagnosed, and importantly, how well it responds to treatment.
But overall, have things improved?
Oh, dramatically. With early diagnosis and the treatments we have now, especially biologics, the goal is often achieving remission, meaning no active disease, or at least low disease activity. Preventing long-term joint damage is much more achievable now than it used to be.
That's really positive.
It is. But we also have to be realistic that some children will have persistent inflammation and may face ongoing challenges into adulthood.
Are there specific prognostic points for the different subtypes?
Yes, there are some general patterns. For Oligoarticular JIA, while many do well, maybe up to half might still have some long-term joint problems. And that uveitis risk is significant. Around 50% might develop eye inflammation, which needs lifelong monitoring in some cases because it can lead to cataracts or glaucoma if missed.
Wow, 50% eye risk. Okay. Polyarticular.
For polyarticular RF negative, the outlook is generally better than RF positive. Maybe about a quarter achieve remission within 5 years. For RF positive, remission rates are lower, maybe only around 6%, and the risk of progressive erosive joint damage is higher. It behaves more like adult RA.
Okay, systemic JAA.
Systemic JRA has a really variable course. Maybe 10% have just one flare and then go into complete remission. About a third have a relapsing remitting pattern. But over half, maybe 55%, develop chronic arthritis that can be quite destructive.
So quite unpredictable.
Yes. For juvenile psoriatic arthritis, maybe around 40% still have active disease years later. And for enthesitis-related JIA, having many joints involved at the start or having hip involvement early on often predicts a more chronic course and potentially needing hip replacement later in life.
So the key message is early. Aggressive treatment can really change these outcomes.
Absolutely. Proactive management and regular monitoring, especially for things like uveitis, are critical to improving the long-term prognosis.
Right, and that leads us to complications. What are the main things that can go wrong or that we need to watch out for with JIA?
Well, thinking about the joints themselves first, we can see deformities develop. Contractures where a joint gets stuck in a bent position. Limb length discrepancies can happen if inflammation affects growth plates near a joint on one side more than the other. Specific finger deformities like swan neck or boutonniere can occur, especially in severe polyarticular disease. You might see accelerated bone age due to chronic inflammation. X-rays might eventually show joint space narrowing, indicating cartilage loss. And particularly in RF-positive poly, involvement of the cervical spine, the neck can be a concern.
And beyond the joints, uveitis is a big one.
Huge! Uveitis carries a real risk of sight loss if not detected and treated early. That's why regular eye screening with an ophthalmologist using a slit lamp is absolutely mandatory, especially for high-risk groups like ANA-positive oligoarticular JIA. And it can be silent. The child might have no eye symptoms at all.
Scary. So screening is vital even if the eyes seem fine.
Critically important. Are there complications specific to systemic JIA? Yes. A very serious, potentially life-threatening one is macrophage activation syndrome, or MAS. It's a massive, uncontrolled systemic inflammatory response. Needs urgent recognition and treatment.
Okay, MAS, watch out for that, and systemic JIA.
Another rare but serious long-term complication of chronic inflammation, including systemic JIA, is secondary amyloidosis, where abnormal proteins build up in organs like the kidneys. And, as we've said, significant joint destruction requiring surgery can happen, particularly in systemic or RF-positive poly-JIA.
Are there other, more general complications?
Yes, definitely. Chronic inflammation and sometimes steroid use can lead to osteoporosis, weakened bones. Growth restriction can occur. There are potential side effects from the various medications used. The disease can limit physical activity, leading to deconditioning and psychosocial issues, feeling different, missing school, effects on mood.
Yeah, the impact on the child's life must be huge.
It can be. Behavioral or educational difficulties can arise too, so you have to think really broadly about the impact: joints, eyes, systemic inflammation, growth, bones, medication side effects, and the whole psychosocial well-being of the child and family.
That's a really wide range of potential issues. It just underlines how important that early comprehensive management is.
Absolutely. Getting the diagnosis right early, getting the right multidisciplinary team involved, using treatments effectively, it's all aimed at controlling the inflammation, preventing these complications, and helping these young people live the fullest lives possible.
Okay, so let's try and crystallize the absolute key takeaways from this deep dive into JIA for everyone listening, especially for revision.
Go for it.
Right? JIA, it's a chronic inflammatory joint disease, starts before 16, lasts over 6 weeks. Crucially, it's not one thing. There are different subtypes. Remember the ILR criteria? Classify these.
Oligo, poly-RF neg, poly-RF post, systemic, psoriatic, enthesitis related.
Exactly. The cause. Still idiopathic, unknown, but likely that mix of genetics, environment, and immune system going wrong, leading to that chronic synovial inflammation.
Which drives the joint damage.
Diagnosis involves the clinical picture joint symptoms, maybe systemic ones, plus investigations like inflammatory markers, CRP, ESR, maybe ANA for uveitis risk, RF for classification, and imaging like ultrasound or MRI, especially to rule out other things or assess damage.
And remember that broad differential diagnosis, especially ruling out infection like septic arthritis and malignancy.
Absolutely. Management is multidisciplinary meds like NSAIDs, DRRs, methotrexate, biologics, maybe steroids plus crucial physio, OT, and support.
Tailored to the subtype and severity.
And prognosis varies, but early diagnosis and modern treatment have massively improved outcomes. Still need to watch for complications. Joint damage, deformities, limb length issues, uveitis, major eye risk,
Yeah.
MAS and systemic JIA, growth problems, osteoporosis, and the psychosocial impact.
Spot on. Understanding those subtypes, their features, the potential complications, that's really central to recognizing it, managing it effectively, and improving those long-term outcomes.
Okay, and with that, we'll wrap up this focused deep dive. We really hope this has given you a clear, high-yield rundown of juvenile idiopathic arthritis for your learning and revision.
Hopefully useful.
For more detailed resources, practice questions, and to really test your knowledge for the MSRA, definitely check out passmsra.com.
And don't forget about freemsra.com for free sample questions, too.
Great resources. Thanks so much for joining us on this deep dive today.